Sun and 6, okay.
Fantastic. Okay, so now we're rapidly rising above. I want to just reintroduce myself very quickly. My name is Michael Stewart. I work at the OI Foundation as the Regional Program Services Manager. I want to thank you all for joining us today. A quick note on some of the rules and procedures we're going to try and follow on this call. So like many of you, the OIF now is practicing good social distancing policies. So we're working from home. So you're all getting a lovely view of my living room right now. But I can imagine looking into many of your living rooms as well. But we just want to let people know that for this call, because there's going to be a lot of microphones, a lot of people on this call. We're at 121 right now, and it's going to probably continue to climb for a while. Please mute your microphones throughout the call. Unless you're specifically called on to speak by one of the speakers here, we just want to make sure that there's not background noise so that we can't hear the speakers. As you all know, dogs will bark, doors will slam, babies will cry, and that's totally fine. But we just want to be able to hear that we want to make sure that we're hearing the information from our speakers. As many of you have already started, I see that you are typing questions into the chat feature. We appreciate that. When the speakers are going, we ask that if you have questions for them, please put your questions into that chat feature. And in a timely way, when they're done, we're going to try to answer as many of them as we can in the time allotted. I do see that people are asking about transcription options. Unfortunately, so we don't have, to our understanding, again, we are sort of also learning about Zoom and video conferencing on the fly, like many of you. We're going to try to get this transcribed as soon as possible once it's recorded, so that the recording we send out has descriptions as well. But we appreciate your patience, and if you have any questions, feel free to send me specifically a message. I'm OIF staff, but my name is Michael Stewart. So with that being said, I'm going to bring it over to Tracy Hart, who is the CEO of the OI Foundation.
Hi, everybody. Thanks, Michael. Thanks so much for getting us started. And thanks to all of you for being here. I see so many familiar faces. I'm loving connecting with everyone here in the US and Canada and all over the world. So glad you're here today. So this is a challenging time for all of us. We all know that. And as a community, I think it's so important that we share information. We share the best information that we have. The OI Foundation is committed to doing that. And so today we bring you two experts who will be talking to you about what we know right now about COVID-19, how it may affect people with OI, especially from a pulmonary and respiratory perspective, but also just in general, information that we know right now. So with that, I am pleased to introduce our two presenters today. They both probably look very familiar to you. Dr. Francis Glorieux from Shriners Hospital for Children in Montreal. He is the chair of the OIF's Medical Advisory Council. And then Dr. Sandy Sandhaus, who many of you know is a pulmonologist from National Jewish Health in Denver, Colorado, and he is also a member of the OIF's Medical Advisory Council and a former member of the Board of Directors of the OIF as well. So we're so pleased that they're here, and Dr. Glorieux, I'm going to turn it over to you.
Thank you very much, Tracy, and hello to everyone. And I understand that the hello goes well beyond the borders of North America. So we're very happy to be with you today. We're indeed going to trying times. Some people say that we're in a war. Just to make things into perspectives, I'm old enough to remember the Second World War, where people were told, today you have to go to war and take a gun to defend your land. And that was not easy. Today we're in a war, but what we have said, stay home in your sofa and look at what's going on. So the situation is a little better in terms of perspective, but it's still, you know, a very trying times. I don't have to introduce the condition to you. You live with it, and at different levels. And certainly, it's not easy every day. The thing to remember in this perspective is that the major defect in your DNA, if you will, is linked to a molecule which is collagen, which is present in bone and make all the problems that you know about bone brittleness and deformities. But that molecule is also present in the lung, and it's an integral part of the lung tissue itself. So any abnormality in its structure will affect also the structure of the bone, of the lung tissue, and its possibility to fulfill its function. So that's why we have to consider that lung is a target of those mutations, and is an organ that we have to consider important in that perspective. So that's really what I wanted to say. I want to say also thank you to Ingun from OIF, because she's been working on preparing this as well in her usual very efficient way, and that's very important for us. The person who really be able to answer most of your question is Dr. Sandhaus, because he is a specialist of lung function, and he's our expert in pulmonology, and he will be able to answer your questions regarding this function and how it's affected, possibly in the context of the coronavirus infection. So Sandy, I leave it to you, and I will stay along for other questions if necessary.
Great. Thank you very much, Francis and Tracy, and Michael. I wanted to thank you for inviting me, and I have done a number of these presentations for a number of patient populations. And thank you also for reminding me that there are international participants from outside the US, and I'll be referring to guidelines that we have here in the US that might be different than the guidelines that you have in your particular countries or even localities. So please listen to what's local. What's local is often best. I'm gonna just show a few slides, primarily because just let me get this going, because there's a lot of words on them, and it sometimes helps to see them as well as hear them. I think the first thing we need to do is talk about some of the terms that you've heard from your newscasts and the like. We refer to the disease caused by this novel coronavirus as COVID-19. And the virus itself is either called novel coronavirus or SARS-CoV-2, because it has 90% similarity with the SARS virus that caused some deaths around the world several years ago, which is also a coronavirus. So I'll refer to this mostly as COVID-19 because it's the easiest to say. And Francis addressed why we'd want to talk about this in OI populations over and above the general public. And I'll kind of talk about that. In terms of general recommendations, the best source for specific recommendations and answers to your questions is going to be your own local physician or medical center, because they really know what's going on in your neighborhood. There are big differences between urban areas and rural areas in terms of numbers of people identified, things like that. And each locality is pretty much putting forward its own local recommendations. Well, please mute your microphones if they're not muted. You can stay informed in the US by visiting the CDC website. They just updated their website yesterday to have a much more user-friendly approach to finding information. And this link that you see on the slide will be available to you beyond this talk. So don't bother writing it down now. That will be provided to you. The general recommendations for everyone, not just people with OI in the US, are listed on these two slides. First is the concept of social distancing, which I'm sure you've heard a lot about. This includes when in public or even when visitors come to your home, they attempt to stay at least 6 feet away from other people in your immediate area. Try not to shake hands or touch the skin of other individuals. If you do that reflexively, you should really wash your hands using the directions that we'll go over in a little while. And the current recommendations from the CDC are to avoid groups of more than 10 people, even if you think that 10 of you can stay 6 feet apart from each other. There's specific recommendations to avoid pretty much all except non-essential air travel. You can make up whatever you want for non-essential. We certainly recommend against going on cruise ships because of the closed environment. It's an incubator for infections to be passed to one another. And in areas of high prevalence, most localities that have major public transportation systems are suggesting that people avoid public transportation unless necessary. For everyone, please avoid close contact with people who have respiratory illnesses, especially acute respiratory illnesses, not chronic disease, but respiratory illnesses that have started within the last 4 weeks or so. If you become sick, whether it's the flu, a cold, or the coronavirus, please limit your contact with others as much as possible. Stay home if you're sick. We call this self-isolation. Family members who live with you should follow exactly the same restrictions that you do. The presumption is if you're sick, family members who live in the same house have been exposed. Other general recommendations, some localities have adopted, especially in the West Coast of the United States, a shelter-in-place directive. In these areas, individuals, whether infected or not, are asked not to leave their homes, except for exceptions that are kind of outlined at each locality. For instance, going to get a prescription, getting food, delivering food, things like that are listed as exceptions to the recommendation that you not leave your home. Important for protecting those around you, cover your nose and mouth when you cough or sneeze. This is independent of whether you have symptoms or not. It's best to cover your mouth and nose with a tissue, immediately discard the tissue, and then wash your hands. Avoid touching your eyes, nose, and mouth with unwashed hands. That's the main mode of entry of this novel coronavirus into the body, is through the eyes, nose, mouth. Clean and disinfect surfaces and objects that may be contaminated with germs. Coronavirus can spread by cough, and the virus can live on solid surfaces for many hours, if not days, depending on the type of surface, if it's not disinfected. Obviously, there's some shortage of disinfectant wipes and things like that. You can go to the CDC website and see how to make your own disinfectant wipe from isopropyl alcohol, peroxide, and glycerin. Most important of all, wash your hands often with soap and water for at least 20 seconds. You've probably heard if you sing happy birthday twice while you're washing your hands, that's a pretty good estimate for washing your hands for at least 20 seconds. I've got my happy birthdays down to 18 seconds, so I do a couple of extra wipes. If soap and water aren't available, use alcohol-based hand rubs with at least 60% alcohol. That 60% figure is specific for this coronavirus and other coronaviruses, that the alcohol content needs to be at least 60% in order to kill the virus. And don't forget to scrub all parts of your hand and continue scrubbing until your hands and fingers are dry when you're using the alcohol hand rubs. Try to maintain a 2-week supply of food and water at your home if possible. And if possible, maintain an extra supply of your prescription medications at your home so that you don't have to visit the pharmacy as often. If you do have to visit a pharmacy, many pharmacies have drive-through prescription pickup or delivery of prescriptions now. Please explore the local options in your area. What about things that are specific to OI? Dr. Glorieux gave an excellent description of why there might be things that are specific to OI. In general, I would consider OI to be in a high-risk group for getting serious symptoms and complications should they get infected. And that's because of the known pulmonary impairment, some mild, some severe, that virtually all OI individuals have because of the collagen abnormalities in the due to the genes that you've inherited. So how does that change, knowing that you're more susceptible? Well, basically, you should take the recommendations more seriously than the general population. In general, the general population that doesn't know anyone who's infected believes that they are that they won't get infected, and they don't necessarily have to follow things strictly. In general, younger individuals have the somewhat mistaken impression that the younger you are, the less likely you are to even have symptoms from COVID-19. Recent data from the US that's based that impression of young people being essentially immune to the ill effects of COVID-19 infection. That's primarily from research done in China, but research in the United States has started to show individuals with severe complications from COVID-19 who are under 10, who are teenagers, and who are millennial adults. So that's the fact is that everyone should be following these things, and individuals with OI should follow these recommendations strictly because of the presumed increased risk of serious complications should you get infected. Now, some of this is dependent on how severe the lung disease is. A big factor in whether you get severe complications is your age. The older you are, the more likely you are that this won't be a simple flu-like illness and that will actually affect things more seriously. What do we mean by more seriously? Well, the major complication that individuals who wind up getting admitted to the hospital have is viral pneumonia. And that viral pneumonia is both sides of the lung. Basically, it affects all the lobes of the lung. And in patients who have survived severe viral pneumonia due to COVID-19, those individuals have been left with some scarring and fibrosis in their lung after they've recovered. Now, we know from other diseases that cause this type of pneumonia and what's called ARDS, acute respiratory distress syndrome, we know that that fibrosis and impaired lung function after recovery can actually, the lung function can actually improve over the months following such an infection and a pneumonia. We don't know if that's going to happen in COVID-19, but it seems likely because the similarities of the pneumonia we're seeing versus the pneumonia that we know from other viral infections, even coronavirus infections going on to recover. So the main cause of death is respiratory failure and organ failure, multiple organ failure. If someone gets ARDS and gets a bacterial infection on top of the viral infection. But please remember, it's with all of the thousands and thousands and tens of thousands of people that have been infected, the total number of infected individuals who've actually died from these infections is a small fraction of those who are infected. We don't know the exact amount because in the US, the testing for COVID-19 is still very much restricted. We expect that if there were universal availability of COVID-19 testing, that we'd find hundreds of thousands of individuals with infection, and that would make the death rate become much smaller. Having said that, I don't want to diminish the risks should someone get infected. And when there are ways to prevent infection, like the recommendations that have been put forward, it would be silly not to try to prevent getting infected. Even if you're a young individual, even if you have no pulmonary symptoms related to your OI or other conditions. And that's all I have in the way of the slides. Mike, if you could turn the screen share off. Great, thanks very much. And I think the most important thing at this point is to answer questions that have come forward. I do want to acknowledge the psychological impact of all the information that's pouring from TV screens, radios, newspapers in a tidal wave at all of us, and the changes it's affected in our lives, the changes in our workplace, the growing economic impact of this infection weighs on individuals greatly. And it's really important to take a break sometimes from the news channels and the newspapers. Try not to concentrate on it. Enjoy your time with family that you might have not had if you didn't have to stay home from work. I'm doing that. I'm considered to be in a high-risk group. In fact, Dr. Glorieux and I are both in the high-risk group of being elderly. And tough to acknowledge that, but happy to get a chance to spend with my wife at home, which is what I've been doing. And only going in when I have to see a patient that has flown in to see me at National Jewish. I reassure you and my family that I'm not working in the intensive care unit because I'm in a high risk group, but there's an amazing dedication going on with the high risk individuals, with the ICU doctors. In my institution, the ICU doctors are doing 24-hour-a-day, 7-day shifts. And then they get 14 days off to self-isolate at home to find out if they've been infected. And then after that 14 days, they come back and do 7 24-hour shifts again. And they're asking retired doctors to come to work and things like that. So I know had an effect on everyone that's listening to this teleconference, and I'm happy to answer any questions. And I'm sure Dr. Glorieux is as well.
Thank you very, very much, Dr. Sandhaus and Dr. Glorieux. Wonderful information. Michael, are you going to facilitate the questions that we've been getting? And so keep typing in your questions as well.
Great. Thank you so much.
Michael, Dr. Glorieux here. Just a practical point I want to add before I forget. Something I do myself every day, confined in my condo as I am because of being a high risk. Take your temperature every morning. It's a very easy thing to do. Your temperature should be below 37.5 Celsius or 99.5 Fahrenheit. And it's an easy thing to do. You do that. I do that after breakfast. And if it's there, I'm comfortable that the day will be okay. So that's just a little thing that we have to add to our day-to-day activities to keep as comfortable as possible. Okay, that's
I second that. Thank you.
Great, thank you so much. So we have, my colleague and I have been keeping a list of the questions you guys have been typing in. Thank you so much for doing that. We have one question from someone who could not make this call today that I think is a good starting off question, and then we're going to jump into the questions you guys have been typing into the chat feature. Again, we're going to try to get to as many as we can. The first question we have is from a Sarah Fisher. She asks, what effects have been seen or are expected for people with OI? And are there added difficulties with treating COVID-19 with people with OI compared to that of other people?
So my the first part of the question, as far as I know, I turned to Tracy to find out if you're doing any tracking of patients that have OI or will be doing that in the future. There's, you know, the number of patients who've been identified because of the restrictions on testing in the US at least, overall has been relatively low compared to the number we think are out there with infection. And in most rare diseases, there is not an effort at this point to find out if there are specific concerns or heightened infectivity, for instance, in people who are have one of these rare diseases like OI. In other words, we don't know. We assume that people with OI and other rare diseases aren't more likely to get infected, but we do think that they, if infected, they're more likely to get severe disease if their rare disease includes lung issues. And so that was the point of my last slide here. And the second part of the question had to do with, see, I already lost it.
It kind of overlaps with the first part. So it says, are there any added difficulties with treating COVID-19 compared to that of other people?
With OI and OI patients, well, you know, putting the final sort of treatment step that happens in patients that get severe disease is they wind up on a ventilator or a respirator, a tube in their lungs with a machine breathing for them. And that is always a risky proposition in people that have fragile ribs, fragile bones, things like that. And so it's really important that should you or a relative find themselves in the intensive care setting, that the physicians are aware of OI and the complications of OI and take special steps to reduce the pressures that a ventilator uses, things along those lines. And, you know, I'd be happy to speak to any physician that is caring for someone who's seriously ill with OI, just to review those things with them, because I'm certain that there are many intensive care docs who have never managed a patient with OI.
Excuse me, everyone, can we just make sure that our microphones are muted? I appreciate it. I will be putting down our organization email. It's bonelink@oif.org if you want to contact us, and so that you can get in contact with Dr. Sandhaus, we can connect you for you. So again, if you're just joining us, can you please just make sure your microphone is muted so that we can all hear the questions and the answers. Thank you. So I'm going to go on straight to the next question then. This is from Izzy PC here on the call. Can someone with a cold still use a incentive spirometer or any spirometer? I may be pronouncing this wrong.
No, incentive spirometer is something, okay. I mean, there's no reason not to use an incentive spirometer. I'm not sure what they mean by any spirometer. The term spirometer usually means a test that's done to measure your lung function, while an incentive spirometer is designed to help your respiratory muscles and your breathing capacity and things like that. So there's not a reason not to use an incentive spirometer, unless it's an incentive spirometer you're sharing with other people, in which case I definitely would not use it.
Okay.
Now, many pulmonary function labs, by the way, have closed down in facilities that are seeing a lot of COVID-19 patients because they've found patients who are identified as having COVID-19 days or weeks after they had a lung function test at the facility. Our pulmonary function lab at National Jewish is closed down because of that.
Mm-hmm. So I want to just keep going. From
You probably
iPhone,
don't need to announce the names, Michael.
Yeah, my daughter has OI and she's pregnant. What should she look out for?
There have been people with COVID-19 who have been pregnant. Number one, the literature that's out there, and it's actually surprising how much is coming out from the experiences around the world. The information out there suggests that mothers with COVID-19 do not pass the infection on to their children, or to their fetuses, They're not being born with COVID-19, and it has not affected their pregnancy beyond the effect of having either a complication from COVID-19 or respiratory issues from COVID-19. So there's no special issues as far as we know right now regarding pregnancy, except you'd certainly think that pregnant women should take extra special precautions, just as general OI patients should.
If I didn't get a flu or vaccine yet, should I risk going out to get it?
This is part of a series of questions I'm sure we're getting that always come up in these conversations, is the risk-benefit analysis of going to get, for instance, alpha-1 antitrypsin deficient patients that I follow, which is another genetic condition, get weekly infusions of their missing protein at infusion centers. And the questions I get about that are, should I skip my infusions so that I'm not exposed to all the people that are at the hospitals or infusion centers I go to? And really, it's a tough question to answer. People need to weigh those decisions themselves. It is quite important to get a flu shot still if you haven't gotten it. Flu is still a much larger killer in the general population than COVID-19 is. Even in countries that have already gone through major, spikes in their COVID-19 infections, like China and South Korea. And so getting the flu shot, it's important. I know that there are some pharmacies that will do that in a drive-by setting in the United States, where you just drive up, stick your arm out of the car and get your flu shot. I would think that in that situation, that the benefit outweighs the risk. Similarly with immunizations against pneumonia, those things are all important to have right now, because the pneumonia that the pneumonia shot protects against is the kind of pneumonia that can complicate a viral pneumonia. So the answer to the question is, if you could find a way to do it with minimal risk, it would be a good idea to get those immunizations if you haven't had them yet.
Next question is, what about the kids? They say kids are less affected. Is an OI child also high risk? Should we maintain isolation? Right now we are home, but what about when it's time to go to work?
So the two things about kids are, there probably is a higher rate of mild symptoms in kids and young adults than in older people. But it's not an absolute, it's not a guarantee that you won't be have some of the complications of COVID-19 just by being young. The other thing is that kids who aren't demonstrating symptoms could well be infected. As you know, even adults who get infected are often asymptomatic for as long as 2 weeks before symptoms start, and during that time can infect others. And so I know that in our area, even kids who don't have intrinsic lung disease, such as the kind that an OI individual can have, that kids are being kept from going on play dates and going to playgrounds and seeing their usual friends. It's a very difficult thing for kids, and especially for parents who have cabin fevered children, in their homes. But still, kids can not only become infected, they can become a reservoir for infecting other kids and adults.
Thank you. I'm going to move to a different question. Recommendations for those in healthcare, please. I'm type 4 moderate, 4-1, pectus chest deformity. I'm a registered nurse, but not bedside, in an office and hospital with a handful of other nurses. The hospitals has yet to have any confirmed cases, but have several PUIs. Thank you for your time and recommendations about what you're already giving the general population.
So PUI is a patient who is under investigation. That's a patient who has symptoms that could be consistent with COVID-19, but does not have a test result back yet or can't get a test, just to clarify what was being asked. And every healthcare provider that goes to work, whether they have OI or not, is making a risk-benefit assessment because they are putting themselves in harm's way. And so I would say that as a type 4 OI individual, the likelihood is that should you get infection, it will be more likely to have pulmonary complications than if you didn't have type 4 OI. And so your decision making is your own. I think at the first sign that there is a growing number of individuals in your community who are testing positive, I think that it would be reasonable to consider stepping back from your work or finding another job in the location where you're working that doesn't have direct patient contact, where you could work in a separate office or something like that. These things can often be impossible to arrange, but I think that you won't be able to help anyone if you become ill and wind up getting sick and sicker than your comrades in the healthcare setting you're working in.
If we get infected with COVID-19 and fully recover, is our lung function forever diminished?
Well, the infection itself will not necessarily affect your lung function once you recover. When I probably wasn't clear enough, when I was talking about the persistent lung impairment, that was in patients who were in the ICU on ventilators who developed what's called ARDS, acute respiratory distress syndrome, where essentially fluid floods into the lungs and it becomes very difficult to exchange oxygen in the lung tissue. If you simply have an infection and get a flu-like illness and fever and a little cough and some increased shortness of breath, and then it goes away, there's every likelihood that it wouldn't affect your overall lung function at all once you've recovered.
I was diagnosed with asthma in 2019. I assume I should be self-isolating, ? And also, what about spouses? Should we be isolating from them if they continue to work outside the home? I have severe asthma with other respiratory issues as well. Should I self-isolate? I'm 21.
Some of it depends on how effective your asthma treatment is. If your asthma treatment normalizes your lung function, then it's likely that you don't have any greater risks. If you get, one of the things that COVID-19 infection does is that it's an interesting guy walking along wherever he's walking. One of the things that COVID infection does, especially when it becomes, the infection becomes severe, the symptoms become severe, is it causes a dramatic increase in the inflammation in the airways. And that can kick up someone's asthma. And so it really depends on, it's not a simple COVID-19 infection without symptoms that shouldn't be a problem related to your asthma. but the sicker that you get with COVID-19, the more it can exacerbate your asthma, make your asthma worse. And so your physician will need to know about your asthma. They would probably intensify your asthma treatment. The tough questions about your spouse working in the general public and coming back, you and your spouse will have to decide on that. That's a decision that almost everyone in the country is making right now, because if people are lucky enough to continue working, that's just something that they have to decide. It's tough to live in the same house with someone and be isolated from them in reality. And so it may be that you simply, make sure that your spouse is doing everything they can to try to avoid infection, and even consider finding ways to work where they're not exposed to the general public for the benefit of your health. I can't hear you, Michael.
My apologies. A garbage truck was driving by. So there's been a recent study waiting to be published about the virus being airborne. How can we protect ourselves from that?
So the virus is there. There's very specific terms for how things are transmitted. The virus is not airborne. The virus is droplet-borne, and that makes a big difference. Airborne transmission can travel for miles. Droplet transmission only travels for about 3 to 4 feet, which is why the recommendation to keep at least 6 feet, the social distancing recommendation says to keep 6 feet from someone. Now, if a droplet lands on a surface, it can survive on that surface, depending on what the surface is made of, for anywhere from hours to a couple of days, which is why we're recommending disinfecting those surfaces that might have been coughed on or sneezed on or something like that. So the droplet-borne infections are very effectively prevented with social distancing, as well as with masks, N95 masks. Ideally, when masks become readily available, it would be worthwhile considering wearing a mask whenever you're outside your home, because they do work to prevent droplet-borne transmission. The only reason that people aren't recommending that now is because of the shortage of the masks and the decision that the shortage should be the current supplies should be used in the healthcare setting first before people start using it outside the healthcare setting. But as presuming that there will be a big influx of mass production and that masks will become more readily available, I would recommend that people who are at risk, like OI patients, wear masks when outside their home. You're muted again, Mike.
My apologies. So regarding temperature, I normally have a higher body temperature. Does this impact that?
It doesn't impact it in the sense that you're not more susceptible to infection, but in terms of impacting the recommendations regarding taking your temperature, yes and no. I mean, most people who have a higher kind of resting body temperature should get different thermometers. But definitely you're looking for a change from your baseline in your body temperature, and so you can, add 1.5 degrees or 1 degree higher than your in Fahrenheit to your baseline body temperature to identify when you should be concerned. So in that sense, yes, you probably have to correct for that. when looking at the recommendations of when to be concerned. In our city, we're not asking people to come and get tested until their temperature reaches 100 degrees Fahrenheit. That's partly because most people who have infection that's symptomatic have temperatures of 103 to 104. One of the things related to asthma patients and patients that have underlying chronic obstructive pulmonary disease, COPD, is that the three things that are asked when you're doing a verbal screening for the likelihood that someone's infected is they ask, do you have a fever? Do you have increased shortness of breath? And do you have increased cough? Well, any patient that has chronic lung disease know that there are many times when they're coming to a physician because they're having increased cough and increased shortness of breath. So a lot of patients that have frequent exacerbations, as they're called, are being told. The key finding to decide whether you need to report to the medical setting is whether you have a high temperature. And high temperature is uncommon in exacerbations of asthma or exacerbations of COPD. And so really, even though you should be concerned when your temperature starts to rise, true COVID-19 infection gives you pretty high fevers. It's not something subtle.
So this goes out to the part we were talking before about mental health and risk-benefit analysis. Would it be safe to go to public parks? Staying in the house 24/7 is stressful, especially having recovered from recent fractures.
It's recommended that people who are in self-isolation and even people who are on this shelter-in-place take some time to go outside, get some sunshine, get some exercise, stretch your legs, get out from the house. You just have to avoid going to places where you're exposed to many other people. If you're going to a park, don't go to the playground where you sit on a swing and you hold the chain, or something like that that someone else has touched 10 minutes before you did. Just take a nice walk through a beautiful location. If you've got one near you, it will help every day.
So I have heard that we should not be taking anti-inflammatory medications. Can this be verified?
So this is based on an anecdotal report from the French literature in which they found that people who had more severe lung problems had a higher incidence of having taken non-steroidal anti-inflammatory agents like ibuprofen, Aleve, things like that. There's a problem with that. People who are sicker are probably more likely to have taken anti-inflammatory agents as they were getting sicker. They probably had higher fevers. They probably took extra to get that fever down, because people have told me that non-steroidals don't do a very good job of lowering the fever in COVID-19. And so it could be kind of a self-fulfilling story that people who are sicker take non-steroidals, and therefore they're sicker, so they wind up in the hospital and in the ICU and things like that. The current recommendations that we're hearing both from local authorities and federal authorities who are asked this question is, don't take beyond the recommended dosages of Tylenol, that's not a non-steroidal, or the non-steroidals, which include aspirin, ibuprofen, naproxen, things along those lines. Take them to reduce your fever and there's a lot of aches and pains that are associated with COVID-19 infection. Take them if you need them, minimize the amount you take, and never take more than the recommended dose.
So the next question is very specific for the OI community is, if we can maintain the social distancing standards, is it safe to swim? Or can the COVID-19 spread in a body of water?
So that's a great question that I haven't heard before. It is true that we know that chlorine disinfectants are highly effective at killing COVID-19. or killing the virus that causes COVID-19. And so I would think if you have a well, regulated pool that uses chlorine, stabilization of the bacterial load in the pools, that you could consider that. I have to say this is off the top of my head based on knowing that chlorine and bleach are good at killing the virus. And I've not seen any recommendations about that. I probably, I don't know what I would say about swimming in the bodies of water other than the pool. I would think that swimming in the ocean is not an issue. With the changes in that come with each wave. Who knows? I wish it was. I wish I was in the middle of a snowstorm when I start thinking about jumping into the water. But that's what we're doing in Denver right now.
So
I have to say that looking at myself on the screen, I'm learning how many times I touch my face, in spite of telling everyone they shouldn't be touching their face.
I see everyone nodding on the screen, so I think we all agree with you. We have a set of questions all related to recovery. So I'm going to sort of like read 3 of them in a row, but they're all kind of the same genre.
Sure.
What is the identifier of recovery? Is it the absence of symptoms, a negative test, or both? Is it true that when someone tests positive, they will test negative after they recover? And once you're deemed recovered, is there any chance that you can still be contagious? And I just touched my face as I said that.
So the recommendations in the U.S. Vary, in fact, from location to location. You do stop shedding virus when your symptoms go away after you've had a COVID-19 infection. For instance, the recommendations at my institution for when you're allowed to go back to work if you've had a COVID-19 infection are that you have to be symptom-free if you've had symptoms for a week, and then you have to have 2 negative COVID-19 tests that are at least 24 hours apart. I know that in New York, they're requiring 3 tests that are negative each, at least 24 hours apart. I do want to get into the weeds a little. The COVID-19 testing that's currently being done looks for the viral DNA. And so to say that someone is negative means they not only don't have any virus, they don't have any viral DNA. You can be positive a week after all your symptoms are gone, but have no active viral particles because we're not measuring whether someone has an active infectious virus. We're measuring whether there's any DNA left that's from the virus in the back of your throat or in your nose. And the testing, for those who don't know, is a swab of the nose and throat looking for this DNA. And so it's a very strict rule, but it also implies that yes, when people recover, they don't have virus anymore. The big question, of course, is can someone get infected again after they've been after they've recovered from COVID-19? The exact answer to that is still not known entirely, but it appears that if you recover from COVID-19, you cannot be reinfected by that version of COVID-19, of the COVID-19 virus. On the other hand, the expectation is that the virus causing COVID-19 will mutate over the months ahead. And so it is possible that people could get reinfected if the virus mutates enough that the immunity you've built up is not effective at stopping it. Have you heard anything else, Dr. Glorieux, about reinfection and things like that?
Dr. Glorieux, you're muted.
No, Sandy, I just heard the same as you. There is no evidence that that may happen, but it's still an open question.
Yeah. Thank you.
So up next, there's a severe blood shortage. I usually give blood. Should I risk going to do this?
I think that you need to call the donation center and ask them, talk to them about the precautions that they're taking. I know that for most blood donation centers, they are doing dramatic disinfection protocols between donors. The one thing that's important to know is that there is absolutely no evidence that COVID-19 virus can be transmitted by infusions or by plasma products. For instance, if any of you are on, for instance, IVIG infusions and things like that, there's no evidence that plasma products derived from blood can transmit the virus. And so there's actually a shortage of blood, and they're recommending that people go. You should assess for yourself the steps that the blood bank is taking to protect the donors. I fully expect that most of them are doing well. I have to say, I have been disappointed by stories I collect from around the country about healthcare workers who are kind of blasé about doing the protective measures. I don't think that would happen at a blood bank, but certainly home nursing. I've had home nurses go into patients' homes and act like they don't have to do any of the things that are recommended, because after all, they're healthcare workers, and this isn't a big deal. They've dealt with viruses before, kind of things. Now, these stories stand out. It's certainly not the general practice of most healthcare professionals, but you really need to be the ones that evaluate what's being done to keep you safe when you're in a healthcare situation, or a situation where you're going to donate blood or consider it.
The next question is, if you have OI but have never had any lung issues, are you still at a higher risk than the rest of the population? And sort of I think a mirror question to this is, are all types of OI patients considered high risk, even people with mild OI?
I want to emphasize that our warnings to OI patients are only based on our clinical opinions, and we mask it by saying they're expert opinions, but really no one's an expert yet on the lung issues in OI. Our opinions basically say we know that there's deranged collagen in the lung of OI patients. We know that OI patients have abnormal lung function, even those with type 1 OI. And we know that respiratory problems are the main killers of OI patients in general, not just in times of viral infection. And so putting those things together, we are presuming that OI patients are likely to have an increased risk of things that focus on the lungs, as COVID-19 does. A given individual who hands me a lung function test that's perfectly normal and has never had a problem with their lungs in their life, can I say whether that person is at increased risk? I can't. But discretion is the better part of valor. You probably want to at least consider that when deciding what you're going to do in terms of protecting yourself. The possibility that even healthy OI patients, healthy in terms of their lungs, could be at some small increased risk compared to the general population.
The next set of questions are about face masks. In lieu of scarf masks, would it help if people wore scarves or bandanas over their nose and mouths when outside? And a similar question is, can you confirm whether or not face masks are one-time use?
Sure. First of all, I'm in an awkward situation because the CDC is now recommending to healthcare workers that they use scarves and bandanas if there aren't any face masks available. There's absolutely no evidence that scarves and bandanas are effective at preventing droplet transmitted diseases. Maybe some of those droplets will land on a strand of wool in a scarf and not get into your mouth. But it would probably reduce a fraction of the risk, but not have the same type of beneficial effect that an actual surgical mask, or even better, an N95 mask will have. What was the second?
Oh, the next question was, are these truly one-time use only?
Well, no, they are in the setting of a plethora of availability of masks. It's always wise to use them once and discard them, because if you're wearing it to protect yourself, once you've been exposed to people who might have droplets, the entire outside of the mask is presumably teeming with droplets of that contain COVID-19 virus that have been stopped from being inhaled by you. And so you'd prefer not to have to put it on again. And you certainly don't want to touch the front of the mask and when you're taking it off and things like that. But in times like this, where masks are in short supply, the fact is the masks remain effective for several days of use before they get entirely saturated, and they have a higher risk of not being effective at blocking those droplets. Remember, the mask is not it can't prevent viruses from being inhaled. It prevents the droplets that are carrying those viruses from getting to your mucous membranes.
Thank you. Are there any other symptoms that we can be on alert for other than elevated temperatures, and which could indicate we have contracted the virus? Also, actually, let's start there.
Yeah, because you see, I'm forgetting the second question
so
often. Right, so do them one at a time. There are a couple of other symptoms that have become prominent, when we talk about patients we've seen, in the doctor's lounge. And those include diarrhea and body aches and pains. So there are some patients that have prominent GI symptoms like diarrhea. And it's not everyone, it's not the most prominent symptom, but it can happen. And on the other hand, aches and pains, like a flu-like illness, are more common than diarrhea, but still not seen in everyone. There have been a fair number of people, since we often do respiratory viral screening in addition to the COVID-19 testing when we do the swabs. We have found a number of people who have both influenza and COVID-19. And so sometimes it's hard to separate the symptoms that are due to flu versus COVID-19.
Thank you. So the second part of this longer question. So we suspect you have the virus, or you suspect you have the virus. Should we automatically go to the hospital to treat it, or should we attempt to treat it at home with any medications our primary care provider may call in for us at a pharmacy?
When you need to go to the hospital, you should not just go. You should call your doctor or the facility. Now, this is not the same if it's an emergency situation. You have to call an ambulance because you're in dire straits. Then you should go to the hospital. But if you're trying to decide, is now the right time to go to the hospital, then you need to call first. And they will question you about the symptoms, what you've done to alleviate them, things like that, and decide whether it's worth the risk of coming to hospital in case you don't have COVID-19 infection and find yourself picking it up there, or whether it's something you could treat at home. And the hospital emergency rooms and medical centers are very good at recommending, home remedies you might try to make yourself more comfortable as you live through the COVID-19 infection, because the majority of people who get COVID-19 just have a flu-like illness that's going to be self-limiting and go away once you develop antibodies against the virus. So it's the first step is always to call your physician or the emergency room to find out whether they feel that you need to come in. Again, emphasizing that if it's an emergency situation, yes, go to the hospital.
Thank you.
Looks like there's some recommendations for ways to make self-made face masks that are on the chat.
Oh, I see, from Foundation Care for Brittle Bones. Thank you. See, a very long link.
We'll get that. We'll get
Yes.
that. Maybe you can make that into a shorter link,
Mm-hmm.
you know, a bit.ly or something.
Yeah. I want to go on to the next question. So this is kind of a related thing to what you just talked about. So if we were to fracture now, while at risk for COVID-19, how do we best handle going to emergency services?
So that's a great question, because in large cities, many of the hospitals are preventing patients from coming in for what they call elective surgery. And for the vast majority, that does not include broken bones. Many medical centers have developed areas of the hospital that they're trying to keep COVID-19 patients free from, and have separate entrances for patients that are not there to be treated for COVID-19 symptoms, but are there for other medical emergencies. So you need to check with your local facility and find out the best way to manage these things. Many hospitals are setting bones in for non-OI patients in tents outside the facility, in an area that they don't allow people who are testing for COVID-19 to come to, and things along those lines. So it's going to be very location specific about what's to be done. If you require some surgical procedure that's not elective, you know, that's the likelihood is that, you know, you'll have to do things according to, you know, they may change you to another hospital. For instance, in New York City, the Hospital for Special Surgery is still doing orthopedic surgeries because that's all they're doing. They're referring all COVID-19 symptom patients to other locations and trying to keep that hospital as free as possible. Probably Dr. Glorieux has some comments from what they're doing up in Montreal. If he
Dr.
gets off mute.
Glorieux, I'm going to unmute you.
Exactly the same way as you just described, Sandy. We try to direct them to areas where they can be taken care of safely, but if it is an emergency situation, you know, that takes the priority.
Okay, I'm going to move on to some more questions. One question is, it says, what about zinc? Does that help reduce the severity of infection?
I can't answer that.
Infection
I don't have any evidence that it would help. I mean, zinc is used, you know, as a kind of over-the-counter medication that's supposed to reduce the risk of viral infections. But you know, certainly there's no evidence with respect to COVID-19.
Yeah. I go along with that.
Mm-hmm. So I have another thing. If very past due on infusion, would you recommend getting it, even if you need to go to the Children's Hospital to get it? So a bisphosphonate infusion.
Right. That, you know, that every patient is making those decisions for themselves, based on what the hospital tells them the risk is and what they feel the risk is. And specifically for bisphosphonate infusions, you know, I would always turn to Dr. Glorieux regarding things like that. Many of these infusions for specific drugs, you know, have such long half-lives in terms of you know, attaching to the bone and things like that, that it's beyond my respiratory knowledge, and I turn to Dr. Glorieux.
Yes, well, you have to do it case by case, but normally you don't want to interfere too much with the infusion rate, because it has a positive effect of the general well-being of the patient. I'm just facing that with 2 patients at the moment, and we have decided to go ahead with the infusions and design in the hospital a specific area, well protected, where they will be admitted without being in contact with anything else, receive their infusion and go back. I think we have to weigh the plus and minuses of the situation, but overall, I don't think it's appropriate to stop the infusion. We can play with the rate, but not stop the infusions because they need it.
That's good information, especially because I imagine you would come up against healthcare providers where they don't see a lot of OI patients who would say, it's just bisphosphonate, you can miss it. You know, and I think that OI patients have to make sure that the person they're talking to understands this is not the usual use of bisphosphonates.
That's right. But, you know, the rate of administration with Zol, which is the one we use the most, is Q6 months. So that gives a little bit of leeway in terms of organizing the treatment. I don't see that as a major issue, but it has to be taken care of case by case.
Great. So on a related note, so would it be helpful to have some of the OI fact sheets that are available on the OIF's website printed out and ready to go in the event you need to go to the ER now? Would these be helpful to ER doctors, or would something else be helpful?
Yeah, go ahead.
I would say that all our patients do have that. They have, they all have a card explaining their condition and telephone numbers on it to call, and these are all phones to discuss the case in more details. So I think that's a fact that we have organized well in the past and is still appropriate.
And actually,
Go ahead. I was going to say it might be worthwhile to make up our own kind of COVID-19. Go ahead.
I was just going to say, on that note, I just wanted to display this really quick slide I had made. So if anyone is curious about more information we have, this is a perfect transition. So if you want to learn more about COVID-19 and OI, on the OIF's main page, we link to OIF.org, coronavirus 2019, which I realize shouldn't be 2020, with new information as it arrives. This is also linked to on our homepage, OIF.org. And if you want to contact the OIF directly, I know Dr. Sandhaus already said he'd be happy to talk with other doctors about this. If you want to get in contact with him, you can reach out to us directly at bonelink@oif.org. Again, like I said before, we're practicing social distancing, so our phone lines are still open, but the most direct way to contact us, I believe right now, is through email. And we're going to get to you very soon.
By the way, the website coronavirus 2019 should be 2019. That's what the coronavirus is called. It's named after the date it was first appeared.
Oh, I see. I'm learning a lot on this call. Okay, thank you. Yeah. So with that being said, it looks like we've covered a lot of questions, and also the time is 2:18. I also want to let everyone know that if you want to go to find more of these fact sheets, you can go to oif.org/information center, where we have all of our medically verified fact sheets, many of them by the doctors on this call with us today. With that being said, I also want to thank all of you for joining us. We're going to be loading this video onto YouTube momentarily in the next few hours, and then posting it on both Facebook and our on the OIF page. On the OIF website, and please reach out to us. We want to be here for you, and thank you so much. And Tracy or Dr. Sandhaus or Dr. Glorieux, if you have any final comments, I'll leave it to you.
Yeah, thank you, Michael. I would just like to thank Dr. Sandhaus, Dr. Glorieux for all of this wonderful information, for bringing our community together in this way. We'll try to do more of these as we go along, if we can, if we need to. But Dr. Sandhaus, Dr. Glorieux, would you like to end this here with some final comments?
Yeah,
Well, we'll certainly, yeah, go ahead. Go ahead.
yeah, I'd like to make one which is linked to the psychological impact of that whole situation. I think that if you are isolated, Jacqueline, sorry, if you are isolated, you don't have to keep for yourself. We have social media and a modern way to communicate by FaceTime, WhatsApp, you know, and social network. Keep that on and stay connected with the people around you, even if not physically, but at least in terms of keeping your spirits high.
Can I say something?
Go ahead.
Hello, I'm Ingun from OIF. I would just like to thank you for allowing international participants on this call. And it's also important to say that the virus is in very different stages in different countries. And it's very important, if people are in doubt, that they should follow the guidelines and the restrictions from their local authorities. And also there might be different rules on who can get testing, who can get to the ER, etc. So it's very important also to seek advice on your local authorities' web pages.
Great, thank you. That's very important. I'm so glad that you're on the call. I would like to just add that it's great to hear the kind of questions that people are asking. You know, as we know more, as we learn more about this, I think you can turn to the OI Foundation to find out the latest things that we've learned, both from any OI patients that we might learn about, or from the general population. As you know, there are a bunch of studies going on with potential therapies against the COVID-19 virus infection, as well as work on vaccines for the COVID-19. None of these are likely to be appearing in your druggist shelf anytime real soon, but at least know that this is going full speed ahead around the world to try to solve this issue.
Wonderful. I guess with that, Michael, any parting words from you on how we leave this call?
No, so again, I wanted to thank everyone. And if you have questions for us, please reach out at bonelink@oif.org. Thank you so much. Stay healthy, and we'll see you soon.
Thanks,
Bye.
everyone.